Hello everyone, let us study today about Azoospermia and its follow-up. Okay, so this is Dr. TSL. Kindly subscribe to my channel, like, share and subscribe. See, Azoospermia means absence of sperm in the semen sample. So this can be of two types. Okay, so which can be obstructive or it can be even non-obstructive. So let us study how to evaluate a case of obstructive or it can be non-obstructive. So if the obstructive means, so from the testes, then the seminiferous tubules, then the epididymis, then comes the vas deferens. So here there is prostate secretion also, and even the secretion from the seminiferous tubules. So then it will come for the external genital through urethra, right? So when obstructive means whatever this flow of channel is there, in this channel there is a obstruction. Okay, so what you should do is you have to check for the pH and as well as what is the volume of the semen. Okay, if the pH is less, and the volume is also less and there is no fructose, remember fructose will come from seminiferous tubule, so there is no fructose. Okay, so that means there is some obstruction. So what you should do is you check the post ejaculatory urine. Okay, post ejaculatory urine you check to rule out retrograde ejaculation. If in post ejaculatory urine, if you have significant sperm present in the post ejaculatory urine, then it means this is a case of retrograde ejaculation. Okay, so you have checked the pH of the semen, whatever the semen sample, pH, volume, low pH, low volume, low fructose. Check for post ejaculatory urine. If sperm is there, that is retrograde ejaculation. If in post ejaculatory urine there is no sperm, okay, so then there is no sperm means now you palpate the vas. So vas difference you have to palpate. If the vas difference is very palpable, like it can be of two types. If vas is palpable, you have two options. One is there can be varicocele. Okay, so if there is varicocele, what is the treatment option? You have to ligate it, ligation. Or if vas is like firm and all, you have to do transrectal ultrasound also. Transrectal ultrasound to look for the vas status. And if there is dilated ejaculatory duct, so then that means this varicocele or whatever the ligation you will do for varicocele. If the ejaculatory duct is dilated, then what you will do is transurethral resection of ejaculatory duct. Okay, that ejaculatory duct is dilated and it is obstructive. That's why we are not getting the good quantity of seminal volume. Okay, so that time you will do what is called as transurethral resection of ejaculatory duct. Transurethral resection of ejaculatory duct. So this here it is varicocele ligation. Here this is retrograde ejaculation. It can be varicocele or it can be dilated ejaculatory duct. So what is the other thing you will do? Transrectal ultrasound. Okay. So if the pH is normal, pH normal, but semen volume is also normal, so that means normal spermatogenesis, you have to do testicular biopsy. Normal spermatogenesis, testicular biopsy you have to do, and you do scrotal exploration. If you can correct it, correct the obstruction. If you can't correct, non-correctable obstruction. So most of the time what we will do is, if it is obstructive, see like here pH is normal, seminal volume is normal, that means there is no obstruction in the upper genital, like upper part of the tract, right? So and but you are not getting the sperms, but there is no problem with the patient. This retrograde ejaculation is not there, varicocele is not there. That means you assume there is normal spermatogenesis. So for assumption you can do even testicular biopsy. You do testicular biopsy and find out there is normal sperm is there. So when sperms are normal, like sperm is normal and even the upper part of the tract is normal, then what you do is you do scrotal ultrasound. Inside the scrotum any problem is there or not, you have to do it. So you do scrotal exploration and then there's something called as vasogram. Okay, so after doing this, if you find out some obstruction, if it is correctable, correct the obstruction. If it is not correctable, you label it as it is a non-correctable obstruction. Okay, so what I have to do if it is an obstructive azoospermia? So sperm is there, but the thing is it is not coming out, right? So if it is obstructive azoospermia, so the most best method to do is you can do percutaneous epididymal sperm aspiration or microsurgical epididymal sperm aspiration. So when there is obstruction, what you do is aspiration. So here it is 61% sperm retrieval rate. Here it is 93% of sperm retrieval rate. Okay, so this is with respect to the obstructive azoospermia. So when it comes to non-obstructive azoospermia, here there is no problem with the tract is normal. So but the problem is which lies in the testis, or the problem may lie in the upper HPO axis. Okay, so here what you will do is you check for hormones level. Hormone, what is the FSH level, what is the testosterone, what is the Y chromosome status, whether is there any Y chromosome microdeletion is there. So what is the karyotype, is the karyotype is normal or abnormal. Then you look for testicular volume. Okay, if the FSH is less and even the testosterone is less, and then you check for LH, prolactin, and you do MRI, look out any pituitary lesion is there. Okay, mainly pituitary lesion. Okay, but here FSH is not less, but testosterone is either normal or it is excess. It means either the patient may be taking exogenous testosterone. If the person is taking exogenous testosterone, then the testosterone is normal, but the FSH is less. That you have to take. So if every of this thing, hormone, everything is normal, then you rule out any obstructive causes there or not. So you have to, if everything is normal, rule out obstruction. Okay. Or now FSH is more. If the FSH is more, you have to check for any genetic material. So you do one karyotyping. Another is most common what we do is CFTR mutation. Sorry, cystic fibrosis transmembrane receptor. So if that is mutated, you will label it as cystic fibrosis mutation. Or you even check for Y chromosome microdeletion. If that is there, that is idiopathic spermatogenic failure. Here you can't even take the husband as a sperm donor. Take the husband's sperm. You need donor sperm. Even when you take the donor sperm, you have to do genetic analysis and rule out Y chromosome micro deletion even in donor sperm. Okay, so in Y chromosome micro deletion, what we get is idiopathic failure, idiopathic spermatogenic failure. If this happens, then what we are supposed to do is, we can't do aspiration here. In this case, what we have to do is, we should do testicular extraction, testicular sperm extraction. Okay, microtessy, or we can consider doing IVF or intracytoplasmic sperm injection, or we can even consider donor sperm, or at the last is adoption. Okay, in the here we can't consider testicular like aspiration. Aspiration, if we want to do, it is only testicular sperm aspiration. This is not PESA or MESA. Okay, so this is very small in brief regarding azoospermia, like how to evaluate. So what are the causes of obstruction, non-obstruction, so and then how to evaluate each cause, and to come to a conclusion. This is a very small video regarding azoospermia. Thank you. Hope you liked it, and do comment in the comment section.